I would like to thank the organization committee to inviting me to speak at that conference today. And this conference has quite a special place in my heart, because not only have I been part of the AGN and the Medicina Corps throughout my time as a medical student and in my early medical career, I also had the privilege to be part of the organization committee for the 2003 AGN Congress. And it's always a great pleasure to come back to this conference and see all this great work around emergency medicine. Just a few things I want to disclose. Now, we heard a really great talk just previously about resuscitative hysterectomy. Now, this in general is a extreme low occurrence, but what isn't a low occurrence is birth. And all of you here have been born, and all of you needed some form of resuscitation, but we don't call that generally resuscitation, we call that stabilization. And what I mean is, everyone here required cord management, required drying and stimulating and keeping the baby warm. And if you were born before 2000 or potentially 2005, all of us would have gotten 100% oxygen, because this was the current approach. So even term babies would have gotten 100% oxygen via face mask. Now, the good thing about this is that 80 to 90% of all babies will breathe and cry at birth and don't need extra help than these initial steps. 10 to 20% need respiratory support. An extreme small number of babies would require advanced resuscitation, including chest compression and epinephrine. And I saw a really amazing poster out there from the group here from Graz with Gerhard, Bernhard, and Narie, who summarized the number of pre-hospital births here in the state of Styria over the last 7 to 8 years. And there were a total of 173 unplanned out-of-hospital births, so roughly 23 per year. The majority, as you can see, were term infants. Small amount were preterm. Most of them survived. And one point I took out was this admission temperature, notably for preterm babies. But this was rather low, and I will get into that in a few minutes in more detail. But what is most important, that most emergency physician will never see one of these unplanned out of hospital births, and if they are called to one, they're generally term infants. So we really will focus this talk mainly on term infants. Now, these are the latest published resuscitation algorithm. You can see in the left the one I generally use. This is the one from North America, from the American Heart Association and the American Academy of Pediatrics. And on the right side, you see the one from the European Resuscitation Council, which is the one which is used here in Austria as well. And I will go through each of these steps throughout my talk. What I will skip is the advanced resuscitation, just because of time constraints within this talk. One thing I want to highlight, which is not in the European resuscitation guidelines, but it's in the American Heart Association and the American Academy of Pediatrics one, is this newborn chain of care. What is the newborn chain of care? Well, the newborn chain of care is mimicked from the chain of survival, but survival is not our main problem, because the majority of newborn babies survive. So this newborn chain of care makes sure that from prevention, so that the pregnant person is healthy, antenatal care, screening, to recognition and activation when there needs advanced care for the pregnant person, to when then the baby is delivered, the initial steps, which are important for all babies. As I said, 10 to 20% need ventilation, even less need advanced resuscitation, and then it's about postnatal care, focusing on thermoregulation, breastfeeding, and bonding, and then recovery, which, as you can see, is a toddler and not an infant, because the recovery can take many years thereafter, and often is a lifelong recovery if anything happened around birth. Okay, now let's start with fetal to neonatal transition. I thought I'm going to talk a little bit about physiology before I have a few cases where we can discuss what we should do. Now, the fetal to neonatal transition is the only time in your life where your lungs can be fluid filled and you not drown. And to transition from the womb to independent life thereafter, we have two major transitions where we can work at birth when we are faced with a newborn infant, which is the respiratory and the cardiovascular transition. Any other organ system will transition as well, but there is nothing we can actually do around the time of birth. From a respiratory transition, that's the most important one. There needs to be clearance of the air liquid. Then the lung needs to be aerated. This all translates into onset of continuous breathing and gas exchange. On the cardiovascular transition, we can close the vascular shunts, and the coordination of the ventricular output will change from parenteral to a serial output, which just means that the blood is pumped from the right ventricle through the lung into the left ventricle and then into the body. And this is an interdependent sequence of physiological events, and if we don't get those sequence correct, the baby will suffer some consequences. So respiratory transition is first before there is the cardiovascular transition, which means we have to clear the air liquid, we need to aerate the lung, and then hopefully the baby starts spontaneously breathing. If not, we continues to provide positive pressure ventilation. Once we start aerating the lung, the pulmonary blood flow starts to increase because oxygen is one of your biggest vasodilator, so that you can relax the pulmonary arteries and start pumping the blood through the lungs. And this then basically triggers the cardiovascular transition. We just had this great talk about the resuscitative hysterectomy, and in general, the majority of babies born out of hospital will be vaginal birth, and cesarean sections, cesarean births alter how the liquid is cleared and the lung is aerated, slightly because there was no labor. And while this is a rare event, given what we just heard before, maybe something you are also involved with. While with vaginal delivery, it could be a relatively quick clearance of the lung liquid. With a cesarean section, it could take several minutes until all this lung liquid is cleared. And umbilical cord clamping timing will also affect how the transition, particularly from the cardiovascular perspective, is occurring. Remember, a lot of blood remains in the placenta, and when you clamp, you suddenly have less blood volume available. You reduce your preload. It's like in a shock situation, and the body the heart, and so have to adjust with having less blood volume available, need to slow down the heart rate to be able to fill the heart to get an adequate stroke volume. Classic part of the Frank-Starling mechanism. Now, how does it look like? Now, the lung is fluid filled, and you want to get all the fluid into the lung interstitium. And only if you get the fluid into the lung interstitium, you can get gas exchange. And gas exchange is that what we need, because only with gas exchange we can oxygenate, and only with gas exchange we can see an increase in heart rate. If you have no CO2, then you will not see an increase in heart rate because you haven't achieved gas exchange. What could you do pre-hospital? Well, you could add a exhaled CO2 monitor, whatever you use, like an end-tidal CO2 monitor, for example, or what we often use, a PD cap, because this will help you to see once the CO2 is there and when gas exchange is occurring. How quickly is this in a healthy term baby being born? Well, it can take 10, 20 to 30 seconds until you start seeing CO2. So even though the baby is a term baby breathing spontaneously, vaginally born, it could take some time. And it's not something which is immediately with the first breath. Just to remind you, because breathing is generally more effective than positive pressure ventilation, so when you do positive pressure ventilation, this might be even further delayed. Now, let's go through a few cases. Let's start off with a 40-week gestation baby. You could call to that in your ambulance. There's one baby, there's a little bit of blood in the amniotic fluid, but nothing else. And when the baby comes out, still attached to the cord, the baby has good muscle tone, is breathing spontaneously, and it looks like that the airways are clear. What would you do? Correct. Umbilical cord management is our first step, and we should defer the clamping of the cord for at least 60 seconds before we actually clamp the cord. Why is that important? Well, at least in preterm babies, less than 32 weeks, it reduces mortality by up to 30%. And that's quite important for any of these our premature babies, because we will have higher survival. In addition, in term babies in particular, while there is no difference in mortality just because of the vast number of term babies surviving, the iron storage even 6 months after birth is significantly higher, and higher iron storage have been linked to higher IQs, and therefore it's an important aspect of why we do deferred cord clamping even in term babies. How does it look like? Well, when the baby is delivered, baby comes out, and then you just, once the baby is out, now this is a baby born with their legs first, and I would like to thank Anoop Kataria for these videos. Then you just do 60 seconds of delayed cord clamping, you stimulate a bit, and then once the 60 seconds are over, you clamp the cord. What else do we need to do? We already talked about this briefly. We need to maintain normothermia. We try to keep the baby between 36.5 to 37.5. If needed, we can do tactile stimulation or clear the airway. Now, I mentioned earlier in this slide from the group from Graz that many of these preterm babies were rather cold, but we as the neonatal team in many neonatal hospitals, we are not much better. We often also have rather cold babies, so many of our babies are hypothermic, and we still struggle to get these babies normothermic admitted to our NICU. Why is it so important? Well, for every 0.5 degree of hypothermia, you get an increase in mortality of 7 to 8%. So 1 degree colder, you have a mortality of higher of 15%. And that's concerning, and therefore we want the babies in a temperature of 36.5 to 37.5. All right, now let's do the next one. Again, we have a 40-weeker, 1 baby, there's a little bit of meconium and the amniotic fluid, and otherwise there are no additional risk factors. I just want to briefly also mention that these scenarios are from the Retain Serious Games collection. Now, the baby is still attached to the cord, has poor muscle tone, is apneic, has a bad head position, but the airways are clear. Again, what's our first step? Cord management, correct, but this time we can't do deferred cord clamping because the baby actually needs to be breathing spontaneously or get respiratory support that this actually works. So in cases where the baby isn't breathing, deferred cord clamping isn't possible. What's the alternative? The alternative would be cord milking. Now, we can't do cord milking in babies less than 28 weeks because animal studies have shown that you get this fluctuation of the cerebral blood flow, and with this fluctuation of the cerebral blood flow you get a higher risk of potential intraventricular hemorrhage, and randomized trials have actually shown that this can occur, that there is a higher rate of intraventricular hemorrhage. But in term babies, studies have shown that this is related with lower rates of moderate to severe hypoxic ischemic encephalopathy, and so associated with less asphyxia, and that's actually a really good thing because less asphyxia, less moderate to severe hypoxic ischemic encephalopathy will mean more healthier babies. How we do this? Again, very simple. When the baby's out, now this baby is not floppy because it's often challenging to get them. You just strip the umbilical cord up to 4 times. You strip it towards the baby and release it to get in refill, and then you strip it again. Okay, now we have done this, but the baby remains with poor muscle tone, baby is apneic, head position remains bad, and the airways are clear. So I'm going to reposition the head, and then we have to give, because this is the European resuscitation approach, 5 inflations of 2 to 3 seconds to aerate the lung, and then we would reassess and potentially repeat this approach. As this is a term baby, we would start with around 30 centimeters of water, a PEEP of 6 roughly, in 21% oxygen. Now, whenever we use a face mask, there are certain pitfalls we need to think about. Number one, and we talked about earlier this morning in the pediatric session about children getting laryngospasm because of some of the drugs they're receiving and what you can do to overcome this. In newborn babies, there is a different reason why they have laryngospasm. In newborn babies, they can get laryngospasm, or as we would call it, the vocal cords getting closed because of hypoxia. So sometimes when we have babies at birth, you can see that the vocal cords are closed, as you can see here in these rabbit pups, that the glottis is closed, and only once the glottis is open, you can aerate the lung, and only when the whole lung is aerated, these vocal cords remain open. While if the glottis is closed and you provide positive pressure ventilation, you potentially blow a lot of this air into the abdomen, into the stomach. How can you overcome this problem? Well, oxygen can help to overcome hypoxia, or stimulating potentially would be another way of overcoming this. Another thing we frequently see is you have a heart rate, like in this case 87, and you put the face mask on, and suddenly the heart rate drops down to, in this case, 58. And then we always wonder, well, what happened? Well, what happened was that you placed the face mask correctly around the mouth and nose, but you triggered the trigeminal nerve, in particular the mandible and the maxilla branch, which is around the mouth and nose. And with that, you can actually see bradycardia or apnea, and this is a couple of studies in particular, like preterm babies or late preterm babies, where up to 50% of these babies, they become apneic and then bradycardic, and it's a few seconds after you place the face mask, and it takes up to 30 seconds. So that's certainly something you should be aware of if you use a face mask. A lot of time we see mask leak, and it doesn't matter who is doing mask ventilation. It can be myself, and I one time have really good performance with low leak, and the next time I have a lot of leak. And this is again unrelated to yourself. It's just often related to how the mask is fitting, how the face is. So that's certainly something which is occurring a lot. There could also be area obstruction, and that could be because the head is potentially placed wrong, or we're pushing too hard onto the newborn's face. Now, we generally use face masks, and alternatively we use nasoprom, something which has started to be used more frequently in the last few years due to some guidelines changes, at least in North America, where supraglottic airway devices are more recommended as an alternative even to face mask, are now used. So pre-hospital, the supraglottic airway might be your best bet, because you potentially never get leak, like mask leak or leak around the supraglottic airway device is less. You don't get the triggering of the trigeminal cardiac reflex, and studies have shown that comparing face mask with laryngeal mask, you get improved with less failure with the device, less intubation, and it just crosses one, but it has the potential to reduce admission to the NICU as well, and in general it's very easy to use in any of these newborn babies. The guidelines tell you to use a PEEP of 6 whenever you provide positive pressure ventilation. PEEP adds some additional benefits, like establish and maintain FRC, improves lung compliance, less airway rescission improves oxygenation. And how does it look like? Now, these videos are courtesy of Professor Hooper, and you can see here on the left a positive pressure ventilation of a rabbit pup, in this case with no PEEP, and what you can see is here air, and down here you can see how the air liquid interface is moving up and down with every inflation, because there is no PEEP, and that means there is just not enough pressure to keep the lung open, and it takes quite some time to aerate the lung. While in comparison, when you would use PEEP, you can see how the lung stays open, or the airways stay open. They do not collapse. There is no movement of lung liquid back into the airway, and aeration is significantly faster compared to using no PEEP. Now, I know that in emergency rooms it's often challenging because there's not always T-pieces available. If T-pieces are available, and this is the one here on the right, this is what we use routinely, which provides the set PEEP, then it's certainly beneficial. If you only have a self-inflating bag, then ideally you add a PEEP valve to provide some some PEEP. Now, there is not much data out on term babies, but in extreme or in preterm babies less than 32 weeks, using PEEP versus not using PEEP, and or using a T-piece versus a self-inflating bag significantly improves outcomes. All right, now the next question is, how much oxygen should we use when we start resuscitation? Well, as I said earlier, most of us, if you were born before 2005, you would have received 100% oxygen, and then in 2005 there was a reckoning where we switched from high oxygen to low oxygen, to 21% to 30%, and now with the latest 2025 guidelines, there is now a reversal of this, where we say, well, we don't know how much oxygen we actually need, we should start low, but you can also start high and wean down. So there is this uncertainty at the moment how much oxygen we should use. Why? Well, in particular, randomized controlled trials in babies who were born less than 32 weeks showed that half of them, regardless of what oxygen concentration you start, do not reach 80% oxygen saturation at 5 minutes. And if you don't reach 80% at 5 minutes, then you have higher risk of death and higher risk of major morbidities. In addition, at 2 years of age, you even have worse neurological outcome. So, main target for any baby born should be that we should reach 80% oxygen saturation measured with a pulse oximetry at 5 minutes of age. You could always start high, because high oxygen has the advantage that it potentially is a breathing stimulus, so it helps stimulate your breathing. Babies breathe deeper with it. But whatever oxygen you start, and the most important part is that you are titrating the oxygen based on oxygen saturation, so that you don't have a baby which is hypoxic or hyperoxic. And with this, I would like to close. Here is a summary of the neonatal life support key messages from the European Resuscitation Council. As we discussed, deferred core clamping for at least 60 seconds. If the baby is not responding, apneic or floppy, then cord milking if they're older than 28 weeks. Dry, wrap, stimulate, keep warm is the most important aspect of neonatal stabilization. Inflate the lung is your second most important step if the baby isn't breathing. And there we said we need some PEEP. Oxygen. We didn't talk about chest compression and drugs because these are extremely rare. If you have a preterm baby less than 32 weeks, you might need an alternative approach, like a plastic bag to keep the baby warm. Towels do not help you to keep the baby warm. Out of hospital births require an altered approach, and we discussed this hopefully in the last 30 minutes. We try to involve the parents as soon as possible. And with this, I would like to thank for your attention, and I'm happy to answer any questions.